right, hello everyone, and thank you for joining us. I am just giving folks a few minutes to come in and get settled into the virtual room. I will start us off here in just a minute. All right, well, let's get started. Thank you all for being here today. This is our second rulemaking meeting focused around listening to the feedback of people who are joining us today as participants. We're focusing today on approved services. This is part one of two parts where we're going to be talking about approved services. My name is Ariel Finney. I am the Law Cares Fund Policy and Rules Manager. I'm joined today by Vicki Bouvier, our Law Cares Fund Workforce Policy Manager, as well as Debbie Blackner, our Law Cares Fund Provider Network Capacity Program Manager. Today we're focusing around DSHS rulemaking activities. So while Law Cares Fund does span Employment Security Department and Healthcare Authority, as well as DSHS, today we're talking about DSHS, or the Department of Social and Health Services, rulemaking activities focused on approved services. Our agenda today is quite simple. Most of our time is dedicated today to discussion, but we're going to start off with some housekeeping, go over some common terms, and then talk about the approved services that we're focusing on today. Again, this is part one of two parts. So please make sure that you are also registered if you are interested in these subjects for our second part next Wednesday, April 3rd from 3 p.m. to 5 p.m. We'll be discussing all the approved services we don't talk about today. So again, a big chunk of our time is spent around discussion today. So I'm very excited to see the amount of attendees we have in the room. And I'm very hopeful that we'll have some good discussion. This meeting is scheduled for 2 hours. I do expect we may end early, but again, I wanted to leave room for discussion, make sure we can tackle the topics we need to talk about today. But we will give you time back if we end early. Some housekeeping before we begin. We do have the question and answer feature available for questions throughout the presentation today. Similar to what we did in our first webinar, we're going to have some presentation to begin with, and then we will open it up for discussion. Once we go into discussion, I will enable the chat, and you'll be able to use both the chat feature and the question and answer feature to engage with the panelists. And as I said before, we may end a bit early, but we'll really look at how the discussion's going. I do want to revisit some common terms. We talked about this in our first meeting, but I know we have some folks joining us today who was not part of that original meeting. We have a lot of different terms that we use in state services, and particularly within the Law Cares Fund program. And I want to give folks an opportunity to just get familiar with some of the common terms we use and the kind of simplified way we might refer to them. So Department of Social and Health Services, who, again, we're focused on rulemaking for the Department of Social and Health Services today. We often refer to that as DSHS. The Employment Security Department, which is a partner agency within the Law Cares Fund program, we often refer to them as ESD. Healthcare Authority is another partner within the Law Cares program, and we've referred to them as HCA. Long-term services and supports, we'll be talking about some of those aspects today with approved services, and we refer to them as LTSS. Office of the State Actuary has a role within the Law Cares Fund program, more behind the scenes, and we won't necessarily be talking about them directly today, but we do commonly refer to them as OSA. Revised Code of Washington are the statutes for Washington, or the laws for Washington. We refer to them as RCW. Washington Cares Fund, or Law Cares Fund, which you've already heard me say a few different times, we often simplify down to WCF. And Washington Administrative Code, which is really the main reason we're here today, is to develop Washington Administrative Code. We often refer to as WAC. So hopefully this will help kind of create a foundation for you moving forward as we talk, and we'll do our best to explain terms as we use them. But certainly, hopefully this will kick us off on some shared footing. So today we're talking about the Revised Code of Washington, or RCW 50B-04-010 or 010. So this statute includes the definitions for the Law Cares Fund program. And as I talked about in our first rulemaking meeting, Chapter 50B-04 RCW is what governs the Law Cares Fund program and creates rules for different departments and outlines how the program will work. Within that chapter, DSHS is given authority to write administrative code to implement certain sections of their responsibility, or to implement sections of this chapter in RCW. And with that, today we're going to be focusing around definitions of approved services. In 50B-04-010, we have the following approved services. Today we're going to be focusing on only a section of those. As I said before, we have two different parts to make sure that we can really dive deep into the approved services that are listed up on the screen today. Our hope is to include definitions of these services so we can be clear about what does this represent when we talk about long-term services and supports, and particularly, for beneficiaries, what does that mean for them, and for providers, what does that mean for qualifications or how to provide that type of service. So some of these are more broad than others, and we want to make sure that we are clear about what services cover, and also representing, where the boundaries are for those services. So our focus for today are going to be the items up on the screen here. We're focusing on nursing homes, residential settings, memory care, dementia supports, respite for family caregivers, care transition coordination, education and consultation, and professional services. We're going to go through those definitions, and I have Vicki and Debbie here to support me with that. And then we will open it up for discussion at that point. If you have questions as we go along, feel free to use the question and answer feature, and I'll do my best to catch those questions on the screens or on the appropriate slides. Please know, though, as we talk today, our focus really is around approved services. We will talk about provider registration and operational standards, such as minimum qualifications. All of that will be covered in a different meeting where we can be really focused around that topic. So today, again, we're just focusing on the service type, the definition of that service, and what that means when it comes to rulemaking. So with that, I'm going to turn it over to Vicki Bouvier to present nursing home services and some other topics that Vicki is the lead on.
Thank you, Ariel. So I'll just be going through these services and providing brief descriptions. And we'll start with nursing homes. And as you can see on the screen, this is a home, place, or institution that provides convalescent or chronic care for 3 or more patients who are not able to independently care for themselves for a period of more than 24 consecutive hours. Convalescent or chronic care may include administering medication, preparing specialty diets, giving bedside nursing care, applying dressings and bandages, and carrying out treatment prescribed by a licensed healthcare provider. And this description and definition of nursing homes is taken from the statute and rules that are used to regulate them, the licensing rules. And that's the same for the definitions for assisted living and adult family homes are also taken from statute and rule. An assisted living facility is a home or facility where 7 or more adults live and receive basic services for their safety and well-being. Care in an assisted living facility may include help with activities of daily living, transportation to medical appointments and community activities, specialty care, other non-medical services, and nursing services when provided by an appropriately credentialed staff or when appropriately delegated by a credentialed staff. Adult family homes are residential care settings that are home-like, where 2 to 8 adults live and receive personal care, specialty care, room, and board. Care provided in an adult family home may include, again, help with activities of daily living, similar to an assisted living facility, transportation to medical appointments and community activities, specialty care, other non-medical services, and nursing services when appropriately credentialed staff or when appropriately delegated. Memory care is a specialty care that's provided for residents in adult family homes, assisted living facilities, and nursing homes who have dementia. Specialty training is required for this type of residential care. The staff training is for those who provide direct care related to the 3 specialty care types: mental health, dementia, which we call memory care here, and developmental disabilities. And respite care for family caregivers, this is the last provider type that I'll be describing. It is respite care is intended for short-term care of an individual receiving long-term care by a family member. The care is provided to temporarily relieve family caregivers of their responsibilities for providing care. Respite care can be provided in a residential care setting like an AFH, an ALF, or a nursing home, or it can be provided in the individual's home by an individual provider employed under the Consumer Directed Employer in Washington State, that's Consumer Direct Washington, or via a home care agency.
Wonderful. So I'll take over from there. So this next service is called Care Transition Coordination. And Care Transition Coordination is a time-limited service that really complements primary medical care. Care Transition Coordination is designed to ensure proper coordination, timely follow-up, and healthcare continuity with the goal of avoiding preventable poor outcomes as beneficiaries return home from an acute care setting like a hospital or a skilled nursing facility. And those poor outcomes would include something like a readmission or a worsening of a condition. Care coordination is not case management. And so we really want to be clear that this is not case management. But if you or a loved one have recently had any kind of inpatient experience in either an acute care hospital or a skilled nursing facility, then perhaps you have had a phone call, a follow-up phone call from that center, just making sure that medications have been picked up or that the follow-up doctor's appointment with your PCP was made. That would be an example of something that would be a care transition coordination. It's that follow-up that happens during those times of vulnerability for individuals when they're transitioning out of a certain type of facility back into their in-home setting. So Vicki covered dementia supports. Vicki covered memory care, which is care that would happen in a facility of some kind. It could be a nursing facility, an assisted living facility, or an adult family home. Dementia supports also includes supports that we can provide for individuals that choose to stay in their own home. So these would be community-based, non-medical supports to both the beneficiary and their caregivers to improve care for the beneficiary. And that would include specifically developing a behavior support plan with a professional that would help to develop that plan. And it could include providing focused advanced care planning, which would be legal services, very minimal, very focused legal services that would include setting up a power of attorney, that would include all of the various forms of that power of attorney, or to write a simple will while someone still has that capacity to do that. And it wouldn't include any really extensive legal services, such as like a guardianship or writing any kind of a complex will, but really is just part of advanced care planning for an individual that is managing dementia. So those are the supports that we would look for under dementia supports. So under education and consultation, we expect that we would see some non-medical education, the consultation, behavior management, and training regarding a beneficiary's diagnoses and chronic health issues, specifically aimed at helping that individual to maintain their health and safety while they're in the community or in their residential setting. Really just trying to help them better manage their health and wellness and perhaps improving their activities of daily living with some specific education and consultation. Some of that we expect will also include some evidence-based providers, some programs that have been proven over rigorous studies and peer reviews to be effective. And so those would include things like chronic disease self-management, Tomando Control de su Salud, the Spanish version of chronic disease self-management, SAIL, which is a fall prevention program, Otago, matter of balance, and aging mastery. So those are just examples. It wouldn't be limited to those, but we expect that we would have provide some access to those evidence-based programs through the Walk Cares Fund. So professional services is a pretty broad category. Right now, we anticipate that professional services is going to include 3 specific nursing services that we've seen are really important to keep people healthy and moving forward in the long-term services and supports world. And so those include skilled nursing, nurse delegation, and private duty nursing. And so we're going to talk about those in a little bit more detail in the following screens. So skilled nursing is the definition is that it's a service that's intended for short-term intermittent care of an acute condition or exacerbation of a chronic condition when that service is not available through a beneficiary's medical plan. It also would include treatment of chronic, stable, long-term conditions that cannot be delegated or self-directed. And you'll see what that delegation means as we continue on with the following screens. So that's skilled nursing. Nurse delegation is accepted under a role with a registered nurse within their scope of practice. And what it does is it allows an RN to delegate specific skilled nursing tasks to registered nursing assistants or home care aides for beneficiaries that have a skilled nursing need. And so those would include things like oral medication administration, nasal sprays, eye drops, wound care when it's simple and non-complex, blood glucose monitoring, insulin injections. And so it's providing that delegation to and training to caregivers that would be there to administer those tasks. And then private duty nursing. Private duty nursing is a program that provides in-home skilled nursing care to people that would otherwise likely be in a medical institution. And so PDN, private duty nursing services, are individuals who require that are typically dependent on some kind of technology, some kind of a treatment modality, such as mechanical ventilation, complex respiratory support, tracheostomy, or IV or parenteral administration of medications or nutritional substances. It's really to provide individuals an accessibility to live in the community, even though they have these very complex situations with their medical needs. And so it really is about keeping those people where they're in their settings of their choice. And it also is designed to help support families who likely assume a large portion of those individuals' care.
All right. Thank you both, Debbie and Vicky, for giving us a rundown of these different approved services and our definitions. I'm going to turn this over to Vicky first and then Debbie. Can you speak to a little bit about how we came to these definitions? Are we looking to current definitions? Are we creating our own? And I know that may be different for each definition, but if you could speak to that for me, I think that would be helpful.
Me too. So for the group of providers that I presented, several of them are licensed provider types. So adult family homes, assisted living facilities, nursing homes, and home care agencies. So they have a statutorily identified license for particular services that they provide. And so for those types of service, we are using the definitions that apply to their licenses, because we want to make sure that we are not creating a service that doesn't already exist for those licensed service providers. For respite to family caregivers and well, actually, I'll talk about memory care first. Right now, dementia care is something that is identified for long-term care services and supports in residential settings. We are using memory care for those dementia care services because of the way our statute is constructed. We have both dementia care and memory care. I'm sorry, it's dementia supports, isn't it, Debbie? And memory care. And so we're making that distinction, and that would be clarified in our rules to make sure it's really clear what we mean by memory care in those settings. And then respite care for family caregivers, we have a bit more latitude to identify and define what that is. But definitions typically are broader, descriptive framework for what the service type is versus specific types of care. So hopefully that answers that question for those service providers. You're welcome.
So the services that I described are a lot more nebulous than the services that Vicky described, because there's very clear direction on what is an AFH, what is an ALF. Those things are very clearly defined in licensing rules, it's throughout DOH, DSHS, there's going to be rules about that. The services that I described are a lot more vague. And so because we have experience in LTSS, those long-term services and supports over at Aging and Long-Term Support Administration and Developmental Disabilities Administration, we have experience with some of these services. And so the definitions that I provided may look similar, but there are going to be some unique qualities to Walk Care's fund. We won't be bound by the same regulations from the federal government, for example, for Medicaid services. And so we're hoping that we can create some uniqueness in what we offer, but we already have a firm foundation on which we can build. And that's the services that maybe we look very similar to what we provide over at ALTSET and DDA. So if it did look similar to you, that's likely because that was our jumping off point. We have a lot of experience here in Washington State in helping to serve individuals with long-term care needs. And so that was a great jumping off point for us, but we're just expanding from there.
Wonderful. Thank you, Debbie and Vicky, for clarifying that for us. I have opened up the chat for folks who want to contribute in there. I'm going to move us into our first discussion point. So if you want to participate, you are welcome to raise your hand and ask to, and that will signify to me to unmute you. I am going to unmute people in the order in which they raise their hands. I do ask that folks who are unmuted also try to be mindful of making room for other people who want to speak. So try to limit what you're sharing to about 2 minutes. You can always raise your hand again and we can come back to you. Otherwise, the chat is open and you are welcome to participate in that. I will also be monitoring the question and answer or Q&A section as well. So our first question for you all is up here on the screen. I've also included the services that we've talked about today, just to kind of help trigger, where have we been? What is our focus for today? But our first question is, are there any services that closely align with the services reviewed today, but were not discussed? And as you're thinking about that, I'll give you a little bit of background. we're asking this question because in our statute, it says approved services are these types of long-term services and supports. But it's including these, but it's not limited to these. And so with that, we're looking at what's listed in statute and then also looking around to say, is there anything else? And of course, that's a long list. But we want to understand if there's things that are very close to the things listed in the approved services sections that may need to be explored further when it comes to the Walk Cares Fund program. So today we're focusing around services that are closely aligned with the services up on the screen. Again, we'll talk about other services next week, but want to make sure that we are catching anything that may be similar. And I do have a question coming in, and this may be for Vicki, but feel free to send it back to me. Why are ESFs not included? I think that stands for Enhanced Services Facilities.
Yeah. Thank you, Sandra. So the statute right now includes the 3 residential care settings that are identified there, but we are looking to see if and when we could expand that to include enhanced service facilities. The primary reason they are not at this point is that the care level for residents of ESFs and the fact that they come generally from Eastern and Western State Hospital is that we're making an assumption that a good proportion of those folks would not have benefit to use in under Walk Cares. But also they're case managed, and often they qualify outright for Medicaid services. So we are going to look at those as we move forward to see if and when we can add them as a service provider. And I know you are the residential care service program manager for enhanced service facilities. And so any feedback you have for us on ESFs, we'd be happy to hear that.
All right, thank you, Vicki. And we've had 2 questions come in, one of which is regarding adult daycare may fall under respite for caregivers. That is one of our approved services within the statute, and we will be talking about that next week along with in-home care. So we will be covering, again, kind of more of the in-home care topics, other things that are listed as approved services in the statute next week. So please come back for that, and we will get into that topic a bit more. And that's for both adult daycare and in-home care. All right, and so I saw some hands up, but they've gone down. If you want to be unmuted, please raise your hand. All right, and I see a question. I see a hand up, so I'm gonna let Jessica unmute.
Hi, thank you so much, Ariel, Debbie, and Vicki. This has been really great information. My name is Jess Gomez, and I'm the Coalition Manager for the We Care for Walk Cares Coalition, representing about 15 groups here in Washington, from providers to individuals receiving services. And I wanted to make a remark. I believe that it was something Debbie was saying in terms of using Medicaid services as a jumping off point, and something that we as a coalition are tracking is the continuity between Walk Care services and Medicaid services, and the need there for consumers to experience a seamless transition. So while I certainly appreciate and recognize the desire to be innovative, I think it's also important that we try to keep some continuity there, especially for providers who are very used to the sort of menu and options of Medicaid services. So just wanted to throw that in there. Thank you so much.
Thank you, Jessica, for bringing that up. All right, I'm going to turn to Dan next. I'm going to unmute you.
Great, thanks. Dan Murphy, I'm working with AARP. there's a lot here. Is the PowerPoint available, including the speaking points that you all used? It'll take some time to digest that. That's one just request if it could be available.
I will.
Pardon?
And I can answer that, Dan. I will be posting the slide deck on our website. So you're welcome to digest it, and my contact information will be available as well. If you have ideas or thoughts after today, you're welcome to send those in. I should have it posted later this week.
That's great. I'm slower at thinking than I used to be. Then the second thing, and I echo what Jess just said about continuity with Medicaid. However, there's a couple areas where the definitions include limitations that are really might play out differently in WACARE. I'm thinking off the top of my head, nursing services. I think the definition was defined as a short-term service. I get under Medicaid, which is liable for the cost, how you want to put some parameters under that. But under WACARE, if where the benefit is limited per person, if they want to and have a need for nursing services longer than whatever the definition is of short-term, I'm not sure if there's a compelling reason to define it solely as short-term. Maybe just define what nursing services are. And I'll just make that as a comment and maybe ask in those definitions, because Medicaid is so focused on its cost containment, wherever there are limitations that are more fiscally driven than definitionally, take a look at those in these definitions. If somebody needs a service, they need a service. And eventually they're going to run out of their benefit. So there's a fiscal incentive for them to control what they do. So that's just my 2 cents on that.
Ariel, could I take a second? Dan, it's nice to hear from you. It's been a long time. But let's go back to slide 17, if that's possible. I'd love to provide a little bit of a clarification around that definition. So this actually is a definition that does sit in our long-term care manual. And actually the waiver excludes that first bullet. And so the expectation is that would come through Apple Health for a client that was on DSHS. We're including it in WACARE's fund, but we are also including the second bullet, the treatment of chronic issues. And so in WACARE's fund, it would be both the short-term intermittent treatment of acute conditions and the treatment of chronic conditions. So I appreciate the opportunity to provide a little bit of clarity around that. We really are expanding rather than constricting, we're expanding what's available under COPE's skilled nursing, for example.
That is helpful. I read them in combination rather than separately.
Yeah, I should have had a little or under there. So yeah, it's either or. Thank you for helping me clarify that.
Good, thanks.
Mhm.
All right, and thank you for bringing that up, Dan. That was a great clarification. I'm going to move us back to our prompt just so we have that up on the screen, and I'm going to catch up with the chat a little bit. So we have a question about adult day. So both adult day care and I believe adult day health will be covered next week. We will get into that more specifically as the same format we're doing today. I do have a question that I'm hoping that Vicki and Debbie may be able to support me with regarding care coordination. They're seeing a transition benefit, but not care coordination, and then no wellness benefits. So I'm not sure if there's been discussion around that, or that's something we can take note of for our future discussions around what other services may be, good to look at.
I can maybe just offer, one of I think the nice benefits of WACARE's fund is that it's self-directed. And so individuals have that autonomy to decide what they need versus having someone tell them, this is what we think you might need. So that autonomy that individuals will have through WACARE's fund is actually something that we see as a benefit. There will, of course, be people that will help if individuals are having a hard time navigating their choices. There will be people that can help with in the customer care center, for example, if they have questions about how to do something or things like that. So those are things that we'll be looking at. And so I think the absent case management actually gives people full freedom to choose what they think they might benefit from.
Thank you, Debbie. Another question coming in is, if a beneficiary wants to receive reimbursement for a service that's not on the approved list, can they appeal for coverage? And I certainly look to Debbie and Vicky, who are much deeper into these topics than I am. But I do think that there is still a lot of work that, that we're looking at right now regarding this subject. So I see Vicky has unmuted, so I'll pause here.
We are looking at ways to do reimbursement for certain types of services. But that is very much still up in the air, and I believe Mark Towers will be presenting on related services for that type of payment method. And then the only other thing I would say is, in order for the services to be paid, they would have to be added to our list, that language in the statute, including but not limited to. We would still have to define what services and articulate what services are covered by walk carriers, both to make sure beneficiaries have access to the information they need, but we also are responsible for setting rates for the services that are offered and for making sure the fund remains fully funded. So I'm sure Debbie has more information she can share.
Yeah, I think that's just like you and Ariel just said, Vicky. I think there's a lot of things still to be determined as far as what service.
I did want to wrap back around really quickly. If there are things as we go through this, through the presentations over the next couple meetings, that you think are services we've missed, I just want to reinforce what Ariel said at the outset, is we want to make sure that we're considering those, just like Sandra brought up the question of enhanced service facilities. If there are services you think we really should include, we want to hear from you about what those are.
One other comment I'll make about the appeal, beneficiaries will have appeal rights under the Walk Cares Fund program. So certainly an appeal is possible, whether that reimbursement and the service will be an approved, on the approved list for use of the benefit, something we're still very much exploring. So I'm going to call out one comment that was left here in the chat that I think is a good note for us. And then I'm going to turn it over to Kathy, who has her hand raised. The comment is, may want to be cautious about defining services as short-term or acute, since Walk Cares Fund has signaled it might reverse its trigger to a 90-day chronic illness requirement. Thank you for calling that out. All right, I'm going to turn to you, Kathy, and allow you to unmute.
Thanks. I'm Kathy McCall. I'm the advocacy director for AARP here in Washington State. And I came late to the presentation, so apologies, but thank you for all your work on this. A question about professional services. Just in a nutshell, how do you define those?
So currently, what we anticipate is that those will include this specific nursing services. That's what we're seeing a lot of benefit for over in the LTSS world. Those can be critical services to help an individual maintain their community setting, whether it's in a residential setting or an in-home setting. Those nursing services have proven to be really important and critical to remain safely and maintain their health and well-being. So right now, it's skilled nursing, nurse delegation, and private duty nursing.
So, and then what's the education and consultation?
So education and consultation is really about helping individuals manage their chronic disease or their behavior issues potentially. It could include evidence-based programs, but it could include some training that would happen in the home with both the beneficiary and their caregiver on the best ways to help manage their care and to potentially increase their ADLs, their activities of daily living, or to maintain their function.
So so the reason I was asking is that I also work with the Dementia Action Collaborative, and one of the biggest issues that they see and what we see at AARP is people needing professional legal help to set up, even, setting up how their walk care's benefit is used, like a power of attorney with a family member or what have you. Or how to set up
Your advanced
dur-
planning.
yeah, all the
Mhm.
legal documents and and that can become really expensive. And I know the DAC has been working with creating kind of a free legal counseling, but I think there's a limit to what
Right.
they do.
Yeah.
But is there, under that professional services, is there discussion about that type of service?
So actually, we're including that as in our dementia supports. And so we're specifically have included it there, but of course, everyone will have the full array of all of the benefits. Nobody's gonna say you don't have dementia, you can't use this service. But we anticipate that that specific service, and maybe Ariel, maybe you could go back to slide 14. That specific service that would be very focused, very short-term, advanced care planning would for the most part be really critical for people that have dementia. So we're pointing people to the dementia supports to receive that type of service.
And also, the professional services include PT and OT.
So PT and OT, we're anticipating the vast majority of people would receive through their medical plan, and we're trying to really be clear that we're not a medical insurance plan. And so we anticipate that for the majority, there are some services like today in the COPES world, we do have individuals with OT and PT credentials that provide services for us. An example would be home safety evaluations. Those could come from an OT or a PT. Education and consultation could happen with an OT and a PT. So there are services, we're not calling them out specifically under professional services, but they are a provider type that we anticipate will serve under some specific categories.
Okay, thank you.
All right, thank you. I'm going to review some of the comments in the chat, and then we're going to move to our next discussion prompt. Jackie put in the chat, are there known language assistance services? And I am very curious to hear more about that. So Jackie, I don't know if you feel comfortable unmuting or if you can put more into the chat. That would be very helpful. And then I see a question regarding education or transition coordination. Does that include palliative care? And I'm not sure if Vicky or Debbie, if you have an answer for that one, but that's something we can take note of as well.
So palliative care typically is a medical service that really is really designed to help people, be comfortable at the end of life potentially or likely. And so it isn't something that we've explored, but we certainly will make note of this comment as we're looking at what potential our beneficiaries might be looking to receive in the future, while we're trying to keep the definitions really in a non-medical focused way. So maybe that's something that we can definitely talk about. I appreciate the input.
All right, so we're going to move to the next prompt. So you all have a chance to think about it. We've already been addressing this in many ways. So I feel like we have a good foundation to kick this off. But I think, just to call this out as a question for us, the question is, regarding defining the approved services mentioned today, what would you recommend to allow for flexibility of service delivery while being clear of the scope of the service type? And we've already had some really great recommendations in the chat regarding, using short-term or acute or defining things that may create some limitations that may be more applicable to other programs than walk cares. But I will let that marinate for a second and address some questions. A question came in regarding do you need a dementia diagnosis to receive dementia supports?
So that may have come in just as I mentioned that you do not. So everyone will have access. I've, in a very kind of juvenile way of thinking about it, have thought of this as like a vending machine. You're going to go up and you're going to be able to just self-select. There's not going to be a case manager that's going to say you're not eligible for this service or that service. It is something that will be totally self-directed. And so we can point people that maybe are dealing with dementia to these specific services, but anyone would have access to the full array of services that are available.
Wonderful. Thank you. All right. We had another comment come in saying, I hear you say legal support is open to all regardless of dementia diagnosis, but the dementia support slide has legal services after care for the beneficiary with dementia. That definition may need a second look to ensure it's not read as allowable only for those with dementia. And I think that's a good comment, which is why we're here having this discussion to get those extra set of eyes, get that extra perspective to say, give us that critical look. So thank you. Let's see here. And Jackie said, do beneficiaries and the family member caretaker have access to this information and services in their language? And this is a question, I'll open it up to Debbie and Vicki too, if you're more familiar, but I want to research this a bit further to make sure that I understand fully what exactly our plan is from the communications element. I do know that we have plans regarding translation services, and making sure that, that folks can access information in their preferred language. But as far as, services in their language and exploring that further, I want to do a bit of homework on that. So thank you so much for bringing that up, because I think that's going to be important for, really making sure folks can access this program. Thank you for that. Another comment here, education and consultation seems geared towards healthcare information, but maybe it could help beneficiaries understand how WellCare's fund coordinates with Medicare, MedSup, Medicaid, and long-term care insurance. A reminder on legal services, beneficiaries must still fail to perform at least 3 ADLs to qualify for any WellCare's fund benefits. Yes, when we talk about approved services, we're certainly talking about services that would be provided to eligible beneficiaries, and they do have to be eligible by meeting that assistance need for 3 ADLs or more. But I think that's a great call out regarding that definition and thinking about more than just that healthcare information. So thank you for calling that out. All right, and look into the chat or any hands up regarding the prompt on our screen. What would you recommend to allow for flexibility of service delivery while being clearer of the scope of the service type? And again, I really appreciate all the great ideas we've already gotten regarding this. One will move us on to the next one. Our next question for you all is what accessibility or equity considerations come to mind regarding rules for the approved services mentioned today? And certainly language access has already been brought up and a great call out. But what else comes to mind? And I see Jackie in the chat saying location of offices. Use of technology. There's a question regarding whether dementia support extends to art and music therapy.
Yeah, actually, we have music therapy under education and consultation. And just as part of our behavior supports, we mentioned that behavior management would be something. And so we can certainly consider art. We currently have music therapy because that's a licensed, I don't think it's fully recognized by the Department of Health, but music therapist is a recognized modality for behavior management. So we'll take a look at art as well. We appreciate that.
Thank you, Debbie. All right, so in the chat, I see access to services across all areas of Washington, geographically, not just urban and suburban areas. Kelsey said one of the things that I'm thinking of is how to assist people with cognitive changes who may not be aware or forthcoming with their need for assistance with ADLs, and how to help them through intake and access to services. That is a great call out here, and I'm going to use it as an opportunity to plug an upcoming meeting just like this one that we're going to be talking about assessments and eligibility. So stay tuned for that discussion, because I will be focusing a meeting on that as well. I see finding and vetting providers, immigration status. Will this matter in accessing these services? And I don't believe we will be looking at immigration status. And I certainly welcome any of my Walk Cares folks here to jump in if I'm incorrect, but I don't believe that's going to be part of our screening for eligibility. I see cultural and religious equity, absolutely. And then breakdown of what is in each service, as well as nearest location, such as memory care centers near them. Okay, wonderful. All right. Well, feel free to continue to access, or continue to answer this question. I'm going to move us to the next one. And again, if you have thoughts after this meeting, and you remember this question, you say, hey, or any of the questions we've talked about today, feel free to reach out. I'll have my contact information here at the end of this presentation, and certainly happy to get ideas outside of this meeting as well. All right, our next question for you all is regarding plain language. What plain language recommendations do you have for the approved services discussed today? What should be considered to make sure this is easily understood by our audience? And while you're thinking about that, I see a question regarding, will there be several customer care centers statewide? And I believe that our plan is to have a centralized customer care center. They'll be taking phone calls across the state, certainly be available both by phone as well as email, and potentially some other options through our benefits management system that we're still developing. But again, we'll talk more about some of these features in upcoming meetings. We'll get into more detail there. So I see bullet points being a helpful tool for us when it comes to designing plain language administrative rules. I see a link in the chat, which is very helpful. Thank you for including that. So 4th grade language. Keep the infographics coming. They're great. All right, good to know. I see a chart, or what services do you need? Some sort of resource like that with a yes or no drop down to get people to where they need to be. Under education, are there partnerships to help beneficiaries understand where they need to access services? All right. So a lot of the ideas being generated are fantastic. They are going to be outside of the scope of the rulemaking project. Certainly will be helpful resources and helpful things we will want to design to support folks. But for this project, we're focusing around rules, the administrative codes. So just as for some context here and making sure we're grounding in that, how do we make sure that when folks read our administrative rules, they're easily understood? It feels like that's accessible to folks, and that they're able to understand the program requirements, both from a beneficiary perspective as well as a provider perspective, but also, as I imagine many of you will be assisting folks with accessing these services in different capacities. So, how could that be used? So just to kind of recenter us as well around the rules in particular. And I'm going to turn to you, Kathy, for you to unmute.
Just one thing, I think, we tend to lean towards writing for the beneficiary, so the person that's paid into the Walk Cares benefit. But yet I think people rely on family caregivers to be translator, assister, in-person help trying to translate this, especially if somebody has gotten to the point of needing care with 3 activities of daily living. And so just thinking about how we write this and being, even maybe it's, mirrored sites where it's like, here's your experience if are you a family caregiver that's caring for somebody? Because it gets confusing sometimes, like when you use pronouns like your, my, our, but you're referring to the beneficiary and maybe not necessarily to the family caregiver. That can also be confusing because we know oftentimes there's a lot of older adults that are also caring for the beneficiary that may have been the person paying in. Maybe they haven't been paying into the Walk Cares benefit, but just thinking through how that relates, and then, clarity about how far the family caregiver can go in making determinations about the usage of the benefit.
Yeah, wonderful call out there, Kathy, particularly around the language and all the different people who may be accessing it. And that's wonderful. Thank you so much for calling that out for us. All right, I see one more thing in the chat. Under education, are there partnerships to help beneficiaries understand before they need to access services? And so for the scope of our project today, and please jump into the chat or unmute if I'm misunderstanding the question, but for the approved services we're talking about, they would already be, an eligible beneficiary who's approved for services. So from there would be them determining, which services they want. So again, I may be misunderstanding that question, but any services we're talking about today would happen after they're eligible, not before they determine whether or not to access services. Okay. All right, I'm going to move us on to our next discussion point here. And I think we've been touching on this as we go, which is always a nice natural form of conversation. But I'll pose it to you all here before we close. Are there any other considerations we should take note of regarding the approved services discussed today? And again, I have a list of the approved services we've discussed today up on the screen. We'll cover all the other approved services that are listed in statute next week. So please return next week for another discussion around these topics or approved services. Right, Amy, I'm going to allow you to unmute.
I just had a question about on your professional services. If a person is blind or they're deaf, does the professional services include some help with stuff like that? Or is that a consideration in one of these services for people that are deaf or blind?
So I'm assuming there we go. I'm assuming you're talking about somebody that maybe is newly deaf or newly blind, and they're adjusting to a change in their life. So we would definitely be looking at that under education and consultation. And so that's where we would, an individual would probably benefit from that particular service with that array of providers. That there's the potential that we may be looking at other things as well. But I would imagine that would be under education and consultation.
Well, I happen to know somebody that has macular degeneration, and they're going to eventually lose their eyesight. They haven't lost it yet, but they probably eventually will, because there isn't any cure for that, and they're paying into this. So I happen to know there's like those little magnifiers that they can get, but they're expensive. Is that something they'll be able to use their Washington Care funds to get?
Yeah, it's a very good question. So that would probably, that's actually a very good example of education and consultation. It's somebody that's adjusting to a new issue. Whether it's a new paraplegia, a stroke, aphasia, blindness, deafness, that would be something that they're transitioning for. So that education consultation would be the perfect service for someone you describe in your situation. And then in the next webinar, we're going to talk about adaptive equipment and technology. And that's where someone would be able to access those magnifiers, those talking clocks, those talking watches, all of those things that would benefit individuals that are in your friend's situation.
Okay, thank you.
Mm-hmm.
All right, so I see a comment in our chat saying nursing homes, assisted living facilities, adult family homes, and memory care all have admission criteria and or rules they follow for admission that has the potential to slow the process down for someone seeking services. Thank you for calling that out, Carrie, and certainly something we're thinking about in service development. And Beth has a comment regarding, is there a dollar cap per service type? And I know Vicki and Debbie are much more involved in this discussion than I have been, but I know we are looking at rates right now, and much more to come on that discussion. But I will, again, I'll pause here for Vicki or Debbie if you want to share anything more.
I'm happy to. Our statute requires us to set a maximum amount for payment of services for each service type. And that maximum has to be more than the maximum of a Medicaid rate for comparable service. So we are moving forward with researching what those maximum rates for each service type would be, and in the rate setting process.
And I think it'd still be kind of separating out the two pieces here, that the maximum rate and the dollar cap for each service may be slightly different. There's some slight nuances between the two, what the rate maximum is. So is it $10 per quarter hour unit, or can I spend my entire benefit on that environmental modification? And I think those discussions, like Vicki said, are still happening. So I think those are things that are still to be determined.
All right, thank you, Debbie, and thank you, Vicki. Kathy, you can unmute. And if you're talking, I'm not hearing you. I'll put in the chat if you're not able to unmute.
Are you?
There we go. Got it. A little pop-up didn't show up. So that rate setting issue. So for example, in assisted living facilities, they often have like a move-in fee. And I've seen them, you know, anywhere between $1,000 all the way up to $7,000 for a move-in fee into an ALF. Can people use their Walk Cares benefit to pay for that? Or if you put a cap on the fee, does that prohibit them from using their benefit to pay for that move-in fee?
That is a good question, and we're going to be looking at right now. It's framed in whatever services a licensed facility can offer under their license could potentially be part of their rate setting structure. But that's good feedback to have that we could bring back to the economists and talk about those types of fees. And make sure that those more administrative fees that we've acted intentionally about, whether those are included in the rate or not. Does that answer your question?
Yeah, I think there's just more work that probably needs to be done on understanding what those are, and or if these facilities are accepting, you know, Walk Cares, like what kind of, is there specific guidelines or guidance?
And yes, we'll be looking at that. What what's in and what's out, so to speak.
All right. Well, thank you for the great discussion. I'm not seeing anything more coming in regarding our discussion point here, so I'm going to work on closing us up here. But as I said before, if you have thoughts after today or later today, you're welcome to reach out. I do have some resources I want to share, though, up on the screen. And we have DSHS's website for rulemaking. You can find links for registration for upcoming webinars at that link. You'll also be able to access our slide decks after we're done. I will do my best to post them in the same week as the meeting. And that way, if you miss a meeting along the way, you still have access to the material. You can still digest it and reach out. We have ESD's website up on the screen as well. And that's Employment Security Department and the Healthcare Authority's website. Both of them are also doing rulemaking activities at different times. Employment Security Department should be doing some rulemaking here in 2024, but Healthcare Authority, I expect that to be 2025. For general questions about the WACARES Fund program, you can email wacares@dshs.wa.gov, and they'll be able to assist with any general WACARES questions. But for any questions about the WACARES Fund rulemaking process, which we're here today to talk about, you can reach out directly to me. My email is on the screen here, and I will also try to drop all of this into the chat. So I will work on doing that. I see a question coming in before we close. Can someone use their WACARES benefit to make a partial payment if full payment exceeds the max? And I do believe we're still working through that question. So more to come, and I'll do my best to find answers for these questions as we go and address them as we get to those topics in our rulemaking section. All right, so I'm going to try and drop this stuff into the chat for you. And thank you all for being here. Thanks so much for participating. It's been really helpful discussion. I know I've learned a lot today, and I certainly have appreciated all the contributions folks have made. So in the chat, you'll see the links to the websites. Please follow along. And otherwise, I'll see you next week on April 3rd, 3 p.m. for our next meeting regarding approved services. So thank you all so very much, and have a wonderful rest of your day.
Thank you.